Respiratory 103, Chapter 8. Ventilation and perfusion relationship. The ventilation to perfusion ratio. The normal alveolar ventilation is 4 liters per minute. The normal pulmonary capillary blood flow is 5 liters per minute. This makes the VQ ratio equals 4 to 5 or 0.8. Blood is gravity dependent. Because of this, more ventilation happens in the apex, which increases the VQ ratio. And more perfusion happens in the base, which decreases the VQ ratio. The VQ ratio's major effect on alveolar PaO2 and PaCO2. PaO2 is determined by a balance between the amount of O2 entering the alveoli and its removal by capillary blood flow. PaCO2 is determined by a balance between the amount of CO2 diffusing into the alveoli from the capillary blood and its removal from the alveoli by ventilation. In an increased VQ ratio, the PaO2 will increase and the PaCO2 will decrease. And in a decreased VQ ratio, the PaO2 will decrease and the PaCO2 will increase. The respiratory quotient is the ratio of CO2 produced, which is 200 milliliters per minute, to the amount of O2 consumed, which is 250 milliliters per minute, and this is measured in the blood. This is seen by means of internal respiration or the gas exchange between systemic capillaries and cells. The respiratory exchange ratio is also the ratio of CO2 produced to the amount O2 consumed, but it is measured indirectly through breaths. This is seen by means of external respiration or the gas exchange between pulmonary capillaries and the alveoli. Some pulmonary disorders that increase the VQ ratio are pulmonary emboli, partial or complete obstructions in the pulmonary artery or arterioles, such as atherosclerosis or collagen disease, extrinsic pressure on pulmonary vessels, such as a pneumothorax, hydrothorax or tumor, destruction of pulmonary vessels, such as with emphysema, and also decreased cardiac output. Some pulmonary disorders that decrease the VQ ratio are obstructive lung disorders, such as emphysema, bronchitis or asthma, restrictive lung disorders, such as pneumonia, silicosis or pulmonary fibrosis, and also hypoventilation. A shunt occurs when an alveoli is perfused but not ventilated. This is commonly due to fluid buildup in the lungs. This will cause a decreased VQ ratio. A dead space unit occurs when an alveoli is ventilated but not perfused. This is commonly due to poor circulation or obstruction to the capillaries. This will cause an increased VQ ratio. A capnography, which is non-invasive, is a direct measurement of PCO2 and/or the concentration of O2 eliminated. It is also an indirect measurement of PVCO2 produced by the tissues and transported to the lungs. The PET-CO2 or end tidal partial pressure of CO2 has a normal range of 35 to 45, and the PaCO2, which is measured from a blood gas, may differ by 2 to 3 torr. The capnogram, or breath waveforms. Point A to B is post-inspiration and there is no CO2. Point B begins alveolar exhalation and there is some CO2. Point B to C is the exhale upstroke and there is dead space mixed with alveolar gas, which combines more CO2. Point C to D is exhalation continued and it is the plateau of exhaled CO2. Point D to E is inspiration and there is again no CO2. The shark fin waveform is a classic sign of obstruction and is common in asthma patients. The main capnography uses are for seeing ventilation and perfusion relationships, monitoring the patient's ventilation, in which case if their EtCO2 is decreasing they are hyperventilating, or if their EtCO2 is increasing they are hypoventilating, confirming, maintaining, and assisting with intubation, in which case if there is no reading it means you are probably in the esophagus, verifying effectiveness of CPR, in which case if the EtCO2 increases after stopping CPR it means circulation has started again, monitoring sedated patients, in which case if the EtCO2 decreases it means patient is waking up, and it is used for monitoring hyperthermia, In which case if the EtCO2 starts spiking, it's a sign of hyperthermia because our CO2 levels correlate with our body temperature.